The clinical significance of MRD is just starting in the process of being tested for myeloma patients. The reason for that is we've never had the ability to eradicate the disease to the point that it's not longer measurable by standard methods. So MRD is the concept of taking tools that would allow us to go much deeper and therefore quantifying or perhaps even qualitatively determine if there's still a residual disease or not. The hope behind this is that as we understand that, maybe we'll be able to adjust and tailor therapies that are specific for the unique clinical situations. And again, this is a very, very hot topic, but it's only possible because of the advent of great therapies for the disease. At the present time, there's two major ways in which one can go about and detect minimal residual disease. The first one is through flow cytometry and using multicolor, multi-parameter flow cytometry that takes advantage of what we know about the surface markers in clonal cells and therefore can take the detection to a very low level, somewhere between 1 to the 10⁻⁴, 10⁻⁵ clonal cells that you can detect through this methodology, and that is done again in situations where the normal protein analysis would normally reveal that there's no residual disease. So flow cytometry is predominantly done from a bone marrow sample. It has to be a fresh bone marrow sample that is subjected to the analysis via the laser detection of the markers. The second technology is the use of next generation sequencing. This is something that really builds on older strategies where a specific primer was developed for myeloma cells and rather takes a broad approach using all of the known sequences that are associated with immunoglobulin genes to amplify the presence of a clonal fragment. This is rather new. It's something that is just being tested and has been tested in other diseases previously, certainly with a very good track record in the area of leukemias. But we've realized this can be done as well in myeloma, and this is something that can go one level or perhaps even two in greater sensitivity, certainly a 10 to the -6. They both, what they do is they just tell you whether there's residual cells beyond the level of detection of standard methodologies. We know that MRD negativity confers a better outcome, so it's a marker of prognosis, and that's great, but I think what we really need to do is use MRD to individualize therapy for patients. So we need to determine, for instance, if there's a few residual cells, does that matter? Are there some patients where some cells can stay behind and yet they have very good outcomes? And we know for sure there's some patients that appear to have great responses and they relapse quickly. So that may be one of the questions that we need to answer with clinical trial data in myeloma. Can we use this on a real-time basis? And I think that's probably one of the most exciting things. So for instance, you have a patient who's supposed to be in a complete response and then we start doing testing for MRD. Can we use this to gauge efficacy of maintenance therapy, the need for intensification of therapy, or potentially the withdrawal of maintenance therapy? One patient has serial analysis that show MRD negativity. This is going to be a question that's going to take several to many years to be answered because it does require the very careful prospective validation of data points that will tell you that then your clinical decision making is substantiated by your results.